Hello, my name is Dr. Roger Henderson and I'm a GP in Southwest Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Google Podcasts, Apple Podcasts and Spotify. So do please follow us to receive notification about new episodes, and if you like what you hear, and we really hope you do, then do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me on there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings which occur throughout the year. Now, in this episode, I'm going to be discussing ovarian cancer. And this was requested by one of our GP listeners, so thank you very much indeed for that. And we thought it was an excellent topic to look at, because ovarian cancer is the fifth most common malignancy in the UK in females, accounting for just over 4,000 deaths per year, with about 5,000 new cases annually. As we look at a frequency of new patients per GP, that works out at about 1 in every 5 years. But as we all know, it can certainly happen more frequently than that, just depending on statistics. And if we look at all genital tract cancer, then ovarian carcinoma accounts for about a quarter of that, but is responsible for more than half the deaths. And this, as we know, is mainly because of its late presentation. Usually occurs between the 3rd and 8th decades, but has a mean age of incidence of just under 60. Now, one of the reasons why we should be so concerned about ovarian cancer, because the outcome is generally poor. If you look at an overall 5-year survival rate, this is usually around less than about 35%. But despite this, there's been a twofold increase in survival over the last 30 years, and this is primarily being driven by the advent of effective chemotherapy, particularly the introduction of platinum-based agents in particular. Now, there is unfortunately no screening method available yet that has been shown to affect mortality in any significant way. And the UK Collaborative Trial of Ovarian Cancer Screening reported in 2023, and they concluded that screening using the CA125 blood test or ultrasound scans to test for ovarian cancer did not save lives and was potentially associated with some harm. And so at the moment, an ovarian cancer screening program for most women can't be recommended. That may change with time, but at the moment that is why we have no national screening program. Now, NICE guidance has emphasised the importance of us as clinicians being aware of the symptoms and signs of possible ovarian cancer, and they suggest we should refer any woman urgently if physical examination identifies ascites or a pelvic or an abdominal mass which isn't obviously uterine fibroids. They should also carry out tests in primary care if a woman, especially if aged 50 or over, report having specific symptoms on a persistent or frequent basis, particularly more than 12 times per month. And they mention persistent abdominal distension, loss of appetite or early satiety, pelvic or abdominal pain, and increased urgency and or frequency. And they also say we should carry out tests in primary care if a woman reports unexplained weight loss, fatigue, or changes in their bowel habit. They should also carry out appropriate tests for ovarian cancer in any woman of 50 or over who's experienced symptoms within the last 12 months that suggests irritable bowel syndrome, because IBS rarely presents for the first time in women of this age. I think that's an important point to make. According to the 2016 version of Target Ovarian Cancer's Pathfinder report, 21% of women aged over 50 years who had been diagnosed with ovarian cancer were told that they may have IBS when they initially presented to their GP with symptoms. Now, in younger women, a thorough history may often help to distinguish between irritable bowel and ovarian cancer as a cause for bloating, with other symptoms indicating one diagnosis or the other. But as a reminder, bloating related to IBS tends to come and go through the day, be intermittent and related to meals or stress, and be helped by defecation. Whereas with ovarian cancer, the bloating tends to be persistent, lasting all day. It can be there on waking, which is an important differentiating sign, and is usually unaffected by defecation. Now, nice talk about measuring serum CA125s in primary care in women with symptoms that suggest ovarian cancer. And if the CA125 is 35 international units per mil or greater, we should be arranging an ultrasound scan of the abdomen and pelvis. And if the ultrasound suggests ovarian cancer, the woman should be referred urgently for further investigation. And we should be investigating any woman who's got a normal serum CA125 or CA125 of 35 or greater, but a normal ultrasound. We should be assessing her carefully for other clinical causes of her symptoms and investigating if appropriate. Now, do remember there are some considerations I think it's worth mentioning here about the limitations of CA125 blood testing, specifically that around 20% of ovarian cancers do not affect CA125 levels. So we should always be mindful of that. And false negative CA125 results are more likely in people with early stage disease, with non-epithelial cancers and premenopausal status. So they're more common in younger premenopausal women who tend to develop different histological types than those aged over 50. And more than 50% of women with stage 1 disease will have a normal CA125 level. So it's really important, I think, to provide safety netting for these patients and refer them onwards if they continue to have worrying symptoms. We also shouldn't forget other conditions that can elevate CA125 levels and so potentially lead to false positive results. I'm thinking here specifically of things like endometriosis, but also benign cysts and fibroids, along with endometrial, breast and lung cancers. And I think one of the things we sometimes forget as well is that premenopause women should be advised to avoid being tested during a period, as this can cause a temporary rise in CA125. Now, when we look at staging, most females with a known stage are diagnosed late, in other words, stage 3 or 4, than at an early stage, unfortunately. If we look at the common symptoms of ovarian tumours, then obviously things like pain occurs most commonly from a rapidly enlarging malignant lesion or one associated with endometriosis. And as we mentioned with IBS, abdominal girth may increase significantly due to tumour or ascites. Pressure effects obviously can displace pelvic structures, distort the urethra and produce urinary retention or urinary frequency, and very occasionally we may get peritonitis due to rupture. Fortunately, endocrine effects tend to be relatively uncommon, causing menstrual irregularity or virilizing effects, but these are not typically seen. Now, the initial approach to ovarian cancer is to confirm the diagnosis by an exploratory laparotomy. And the standard comprehensive surgical staging approach here would be a total abdominal hysterectomy and bilateral salpingo-oophorectomy, along with examination of all the peritoneal surfaces, an infracolic omentectomy, and biopsies of all the lymph nodes involved and clinically uninvolved areas, along with peritoneal washings. And the further management of a woman with diagnosed ovarian cancer is then determined by the stage and the histology of the tumour. Adjuvant therapy to surgery for ovarian cancer varies according to the stage of the disease, but chemotherapy is involved in the majority of most cases. Stage 1 ovarian cancer is limited to the ovaries. Stage 2 ovarian cancer is tumour involving one or both ovaries with pelvic extension and or implants. Stage 3 ovarian cancer is tumour involving one or both ovaries with microscopically confirmed peritoneal implants outside the pelvis. And stage 4 ovarian cancer is tumour involving one or both ovaries with distant metastases. And parenchymal liver metastases equals stage 4. And as I say, subsequent management depends on the response to chemotherapy where indicated. We do know that adjuvant platinum-based chemotherapy does improve survival in early ovarian cancers, stage 1, stage 2 epithelial ovarian cancers. And chemotherapy is advised for all women with stages 2 to 4 disease post-surgery. The standard regime usually that occurs around the UK is paclitaxel and carboplatin given IV every 3 weeks for around 5 to 6 cycles. But in recent years, biological therapies have been developed as part of the understanding of the molecular biology of the types of ovarian cancer out there. And targeted treatments include treatments like bevacizumab, and this is a monoclonal antibody against vascular epithelial growth factors. And trials suggest it improves progression-free survival and the quality of life in women with recurrent disease, although there is a strong potential for significant side effects. So just summing up, the good news is that ovarian cancer survival is improving and has almost doubled in the last 40 years in the UK. So in the 1970s, for example, less than a fifth of women diagnosed with ovarian cancer survived their disease beyond 10 years. But now it's more than a third. And when diagnosed at its earliest stage, 90% of women with ovarian cancer will survive their disease for 5 years or more, compared with less than 5% of women when diagnosed at the latest stage. And so there is good news there, but the key thing here is to recognise it as soon as possible. And I hope these simple little reminders will help us do that the next time you're seeing a patient where you're considering the possible diagnosis of ovarian cancer. So do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments or ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But in the meantime, as always, thank you so much for listening, and goodbye.